Hi everyone, and welcome to our module on COPD diagnosis. COPD stands for chronic obstructive pulmonary disease, and COPD is a very common chronic lung disorder. It causes dyspnea and cough, and it's progressive and can lead to death. The clinical features and symptoms of COPD fall under several subtypes. The two most important ones are chronic bronchitis and emphysema, and we'll talk about both of these in this video. The third subtype is asthma COPD. These are essentially patients with severe asthma that has progressed so that it is no longer a reversible lung condition and is now chronic. These people have basically progressed from asthma to COPD. This is relatively uncommon, and I won't talk about this subtype very much in this video. In patients with the chronic bronchitis subtype of COPD, the major problem is inflammation of the airways. If you look at this drawing on the screen here, on the left is the airway of a healthy patient, and on the right is what the airway looks like in a patient with chronic bronchitis. As you can see, the airway is inflamed, there's excess mucus, and the airway is narrowed, allowing less airflow. In terms of symptoms, this leads to a chronic cough and production of sputum. And to meet criteria for the chronic bronchitis subtype of COPD, symptoms of chronic cough productive of sputum have to be present for at least 3 months a year over 2 consecutive years, and there has to be no other cause of cough present. In the emphysema subtype of COPD, the major problem is destruction of the alveolar walls. If you look at this drawing at the bottom of the screen, on the left is a healthy alveoli. On the right are the alveoli of a patient who has emphysema. And you can see that the walls have essentially broken down. This is the major problem in patients with the emphysema subtype of COPD. This is caused by inflammatory cells that release proteases, which break down proteins, especially they break down elastin, which causes the elastic recoil of the alveoli to be lost. This is an important piece of the pathophysiology of the emphysema subtype. Because of this, the small airways collapse on exhalation and air gets trapped into the lung. So people with the emphysema subtype of COPD have dyspnea because their alveoli don't work. They hyperventilate to try and get more oxygen into their body with the remaining alveoli that function. And they can have some cough, but it's less than that of chronic bronchitis. So going back to this slide, what I just described for you is the classic picture of pure chronic bronchitis or pure emphysema, but you should know that many patients have elements of both subtypes, and that's why we call their disorder COPD and not chronic bronchitis or emphysema. The major risk factor for COPD is cigarette smoking. The vast majority of patients with COPD are either current or former smokers. Rarely, there are other associations that lead to COPD. Some patients with a history of environmental exposures develop chronic obstructive pulmonary disease. And later in this video, we'll talk about alpha-1 antitrypsin deficiency, which is an inherited condition that can lead to COPD in non-smokers. COPD is a chronic condition with intermittent exacerbations, so patients with COPD will have some baseline level of pulmonary functioning that may not be normal, but then they will intermittently get worse and then recover from that exacerbation. That's the typical course. And almost all patients have some element of dyspnea and cough. As we talked about before, cough is more prevalent with the chronic bronchitis subtype, but dyspnea and cough are basically typical symptoms of all forms of COPD to some degree. Now, like I said before, most patients with COPD have some elements of chronic bronchitis and emphysema. However, the different underlying problems cause different symptoms. So chronic bronchitis leads to a prolonged expiratory phase. If you listen to the lungs of a patient with chronic bronchitis, they will exhale slowly. It will take a long time for them to get the air out, and that's because their airways are narrowed from inflammation and thickening. Bronchi and wheezing are also features that tend to occur in patients with chronic bronchitis because of the narrowing of the airways. Emphysema tends to lead to decreased breath sounds, so because the alveolar walls have been destroyed, you hear less air movement in the lungs. Emphysema leads to air trapping, so the patient's chest can take on a barrel chest appearance. Shown on the screen here is a normal person and a person with a barrel chest next to him. And then finally, some patients with COPD breathe through pursed lips. And by pursing the lips, this causes the pressure in the airways to rise, and this keeps them from collapsing. So pursed-lipped breathing is a classic feature of patients with emphysema and COPD. So you can basically think of COPD as a spectrum with chronic bronchitis on one end and emphysema on the other, and most patients exist somewhere along this spectrum, usually with some features of both subtypes. But in its pure form, a patient with isolated chronic bronchitis is classically described as a blue bloater. The reason this description is applied to patients with pure chronic bronchitis is because these patients are often blue and cyanotic, and that's because they have marked hypoxemia from shunting. So when air cannot get into the alveoli because the bronchioles are inflamed, you have blood flowing past airways not being ventilated. This is called developing shunting, and this will lead to hypoxemia. The hypoxemia causes pulmonary vasoconstriction. This causes pulmonary hypertension, and then these patients eventually develop edema from right heart failure. So for all these reasons, they're described as a blue bloater. In contrast, the patient with pure isolated emphysema is classically described as a pink puffer. For this patient, the major problem is loss of alveoli, and with the loss of alveoli, there's loss of surface area for oxygen absorption. This means that parts of the lung are going to be ventilated, but no gas exchange will occur. And anytime you have parts of the lung that are ventilated without gas exchange, that's called the presence of dead space. So what these patients are going to do is hyperventilate to compensate. They're going to try to ventilate the working alveoli to make up for the dead space where no gas exchange occurs. And for this reason, they will usually be breathing rapidly, and they're called a puffer. Also, the hyperventilation initially maintains their oxygen level so they don't turn cyanotic like the blue bloater, and therefore they're described as a pink puffer. And these are really sort of ends of the spectrum, as I said before. Most patients are somewhere in the middle, with elements of both chronic bronchitis and emphysema. If you think a patient has COPD, the best initial test is a chest X-ray. And the classic findings on chest X-ray in patients with COPD are hyperinflation of the lungs, flattened diaphragms, and an increased AP diameter. If you look at these two X-rays on the screen, on the left side, this is a normal patient. On the right side is a patient with COPD. And hopefully you can appreciate that the lung fields are just much bigger in this patient with COPD. That's evidence of hyperinflation. Also, if you look at the diaphragms on the normal patient, you can see they're curved. They come all the way down the side like this. In the patient with COPD, they're much more flat, and that's the flattening of the diaphragm in patients with COPD. And here are two lateral X-rays. On the left is a normal patient, and you can see that the anterior-posterior diameter of the chest is relatively narrow compared to the patient with COPD on the right. The patient on the right has a barrel chest and an increased AP diameter, a classic X-ray finding in COPD. In another video, I talk about pulmonary function testing in general, but here I'll just briefly review the pulmonary function testing findings you would expect in a patient with COPD. So COPD has the classic findings of obstructive lung disease on pulmonary function testing. So this includes a reduction in the FEV1 due to slow flow of air out of the lungs, and a reduction in the forced vital capacity because less air is able to be pushed out with each breath. The other classic finding in obstructive lung disease is a reduction in the FEV1 to FVC ratio, and this ratio must be reduced to be less than 70% to meet criteria for COPD. A reduction in the FEV1 to FVC ratio is the hallmark of obstructive lung diseases like COPD. In addition, there must be partial or no change in the FEV1 with bronchodilators. So when you administer bronchodilators, if the FEV1 improves, then that suggests that the obstruction is reversible, and that means that you have a patient with asthma. In patients who have COPD, the change is chronic and not reversible, so there should be little or no change in the FEV1, and this distinguishes COPD from patients who have asthma. So both of these findings here, which are bolded, are mandatory to make a diagnosis of COPD. Make sure you know this. They're going to want you to know it for your boards. So I told you on the last slide that patients with COPD have a reduced forced vital capacity. That's because they're less able to get air out of their lungs compared to normal. But you should know that this is the only important lung volume or capacity that's reduced in COPD. All the other lung volumes are increased, and that's because these patients have air trapping. So their total lung capacity is increased, their functional residual capacity is increased, and their residual volume is also increased. And these volumes and capacities I talk about in more detail in the video on pulmonary function testing. Shown on this slide are a series of flow volume loops for patients with normal lungs and various lung disorders. On the far left side is a flow volume loop for a patient with normal lungs. When patients develop obstruction like COPD, what happens is that the flow volume loop develops this scooped out appearance right here. And the worse the obstruction, the more the indentation of the scooped portion of the flow volume loop. And I talk about flow volume loops in more detail in the video on pulmonary function testing. Another test that can be useful in the workup of patients who may have COPD is measurement of the DLCO, which is the diffusing capacity of carbon monoxide. This test measures the abilities of the lungs to transfer gas from the air into the bloodstream. The way this test works is the patient inhales a small amount of carbon monoxide. You may know that carbon monoxide is dangerous, but this small amount is relatively safe. Then the machine measures the amount of carbon monoxide exhaled, and the more that is absorbed into the bloodstream by the lungs, the less that will be exhaled. Based on the amount that is exhaled, the computer calculates a diffusing capacity for carbon monoxide, and then based on patient factors, it compares the patient's DLCO to a predicted value. So a normal result is anywhere from 75 to 140% of the predicted value. Patients who have severe forms of lung disease can have a result for DLCO that's less than 40%. And the DLCO is decreased in many forms of restrictive lung disease like pulmonary fibrosis, which I talk about in another video. But in terms of COPD, the DLCO is decreased among patients with emphysema, but not patients with chronic bronchitis. And as I told you before, many patients have a mixture of both of these, so therefore many patients with COPD have a reduced DLCO. On your board exams, they will almost certainly ask you to know the expected arterial blood gas results in a patient with long-standing COPD, so let's talk about that now. So patients with significant COPD are hypoxemic even at rest and often need oxygen, so the blood gas will show a decreased PaO2. These patients chronically retain carbon dioxide, and you have to remember this to understand the blood gas results that you will get in all patients with COPD. So their PaCO2 is always high, and for this reason they have a chronic respiratory acidosis, because anytime your CO2 is high, that produces acid. As a physiologic response to the acidosis, the kidneys produce more bicarbonate, so COPD patients always have a high bicarbonate. This is a form of metabolic alkalosis that is a physiologic adaptation and response to the chronic respiratory acidosis. And then finally, the arterial pH is usually slightly reduced or low normal. The respiratory acidosis reduces the pH. The metabolic alkalosis raises the pH. In most cases, the pH does not come all the way back to normal, but in some cases, the kidneys are able to generate enough bicarbonate that the pH will be in the low normal range. So I've summarized these results on the bottom of the screen. The normal PaO2 is about 90 and it's reduced in COPD. The normal PaCO2 is about 40 and it's increased in COPD. A normal bicarbonate is 24 and it's increased in COPD. And finally, a normal pH is 7.4 and it's either decreased or at the low end of normal in patients with COPD. Since the FEV1 falls in patients with COPD, we determine their disease severity based on their FEV1. Patients with class 1 COPD have mild disease and they have an FEV1 that's greater than or equal to 80% of predicted. Moderate COPD is 50 to 79% and severe is 30 to 49%. And then finally, patients with very severe COPD have an FEV1 that's less than 30% of predicted. Let's talk about how to differentiate COPD versus CHF. Both of these conditions cause dyspnea and they can both occur in patients who are smokers. Let's start by talking about symptoms. Patients with heart failure can have orthopnea and PND from left heart failure, and you will never see these symptoms in patients with COPD. Patients with heart failure can have cough, so you should be aware that just because a patient is coughing, that does not mean they necessarily have COPD. On lung exam, the classic findings in heart failure are rales at the bases or bibasilar rales. There can be decreased breath sounds at the bases from effusions, and sometimes people with heart failure will wheeze. This is called cardiac wheezing. So just like with coughing, if a patient is wheezing, that doesn't necessarily mean they don't have heart failure. In COPD, patients classically have diffuse wheezing, and then rhonchi is a symptom that's usually only seen in people with COPD. The jugular venous pressure is increased in patients with heart failure, and it can be increased in patients with COPD. If patients with COPD have developed right heart failure and cor pulmonale, then they can have an increased JVP. On the other hand, if they haven't developed right heart failure from their lung disease, then they should have a normal JVP. Measurement of the serum BNP can be helpful in differentiating heart failure from COPD. That's the main use of BNP, is to distinguish heart failure from other conditions. The BNP level is increased in heart failure. It's normal in COPD. The chest x-ray in heart failure shows pulmonary edema, and in COPD it shows those findings we saw earlier in this video, things like hyperinflation and flattening of the diaphragm. If you do an arterial blood gas in patients with heart failure and COPD, both groups of patients can have hypoxemia. What's different is the carbon dioxide level. Patients with COPD retain carbon dioxide from chronic lung disease, so they will have a high CO2 and a high bicarbonate like we talked about earlier. Patients with chronic heart failure do not retain CO2, and in the midst of a heart failure exacerbation, they are usually hyperventilating, so they should have a low CO2. And then finally, if you do a right heart catheterization and you measure the pulmonary capillary wedge pressure, this is a surrogate for left atrial pressure. It will be high in patients with heart failure. It's normal in patients with COPD. I'll finish this video by talking about alpha-1 antitrypsin deficiency, which is a rare disorder that can lead to emphysema and COPD. Alpha-1 antitrypsin deficiency is an inherited disorder. It's transmitted in an autosomal co-dominant manner. What I mean by codominant is that there are two alleles that can be involved in this disorder. The normal allele is the M allele, and the abnormal allele is the Z allele. So patients who don't have alpha-1 antitrypsin deficiency have two copies of the normal allele. They are MM. Patients with alpha-1 antitrypsin deficiency can be either MZ or ZZ. The MZ patients have one normal allele, so they have a milder form of the disease. The ZZ patients have no normal alleles, so they have a more severe form of the disease. And since both alleles contribute to the phenotype, this is considered a co-dominant disorder. As the name implies, patients who have alpha-1 antitrypsin deficiency have decreased quantities or dysfunctional alpha-1 antitrypsin. What alpha-1 antitrypsin does is it's a protein that balances and counteracts the effects of elastase enzymes. And elastase is found naturally in neutrophils and alveolar macrophages. So when patients are deficient in alpha-1 antitrypsin, elastase is overactive, and that can lead to lung damage. The way you can think about emphysema in general and alpha-1 antitrypsin deficiency specifically is that there's always a balance in our lungs between enzymes called proteases, which break down protein structures, and antiproteases, which inhibit the proteases. So in smokers, the smoke causes inflammation and there's too many proteases created. This overwhelms the antiproteases and leads to lung damage, and typically the damage in smokers occurs in the upper lungs. In patients with alpha-1 antitrypsin deficiency, their problem is not an excess of proteases. Their problem is inactive amounts of alpha-1 antitrypsin, which is an antiprotease. So when these levels are low, that also leads to an excess activity of proteases. And this tends to cause lung damage as well, although in alpha-1 antitrypsin deficiency, it's usually in the lower lobes of the lung. So let's talk about the clinical features of alpha-1 antitrypsin deficiency. First of all, it can affect the lung and cause emphysema. There's an imbalance between neutrophil elastase, which we just talked about. This is an enzyme that destroys elastin, and the elastase inhibitor alpha-1 antitrypsin, which is protective. This leads to lower lung damage like we just discussed. There are also problems in the liver among patients with alpha-1 antitrypsin deficiency, and they can develop cirrhosis. The abnormal form of alpha-1 antitrypsin can build up in the liver. This is only seen in patients who have a specific type of alpha-1 antitrypsin deficiency where there is polymerization of the AAT molecules in the endoplasmic reticulum of hepatocytes. Those patients can develop liver damage and cirrhosis, but there are many patients who have severe alpha-1 antitrypsin deficiency but no problems in the liver, and that's because they don't have a form where the alpha-1 antitrypsin polymerizes in hepatocytes. To make the diagnosis of alpha-1 antitrypsin deficiency, you can measure a serum alpha-1 antitrypsin level. There's also genetic testing for some of the common mutations. The timing of manifestations of the disease varies. In the first 40 years of life, that's when the liver disease can present. So a young patient with unexplained liver disease could have alpha-1 antitrypsin deficiency. After age 40 is when the lung features present, and that's when patients can develop emphysema. A super high yield thing to know for your boards about this disorder is that these patients should never smoke. There's lots of evidence that many patients with this disorder, if they don't smoke, will never develop lung disease. What the lungs cannot tolerate is to be deficient in alpha-1 antitrypsin and have smoking on top of that. The treatment is the usual COPD care. In addition, there is an intravenous infusion of pooled human alpha-1 antitrypsin that is available. And so the classic case to know for your boards is a patient with typical COPD symptoms like cough, sputum, and wheezing. The patient will be younger, usually in their 40s. The onset of COPD from smoking at age under 45 is incredibly rare. So if a patient in their early 40s is described as having symptoms of COPD, they are most likely describing a case of alpha-1 antitrypsin deficiency. The patient may be a prior or current smoker, because remember that patients with alpha-1 antitrypsin deficiency who smoke are the ones that tend to get lung disease. Imaging will show emphysematous changes, most prominent at the bases, because that's where alpha-1 antitrypsin deficiency lung disease occurs. And then finally, if pulmonary function testing is done, it will show evidence of obstructive lung disease. And that concludes our module on COPD diagnosis.